go ahead and get started with the global education at UMB. It's going to be moderated by Virginia Rowthorn, and she wears many hats also, and she's here as the executive director for the Center for Global Education Initiatives. And with that, I'll let you have the microphone.
Thank you, Dawn, and thank you, everyone who's here, the holdouts who have made it to this time of the afternoon after such a long, full day of incredible panels. It's wonderful to be here today to share some of our educational assets here at UMB, and we have a wonderful panel for you today. So I am the executive director of the Center for Global Education Initiatives, and also a senior lecturer at UMB's graduate school. And just to give you a little bit of background about our center, we sit in the Office of Academic Affairs. We are a hub, or like to think of ourselves as a hub for global activity on campus, working with all the schools, supporting their own global education efforts, and we have some hallmark programs of our own that you're going to hear about today, as well as some other educational programs that we have at UMB. So this is our center logo, which you're also seeing on our tablecloth. We're very grateful to the city of Baltimore for helping us make this wonderful logo, Glow Baltimore. And one of our hallmark projects and initiatives is our Interprofessional Global Grant Program. And so what I'm showing you is a page from our website that shows past projects that our center has funded. And as Jody Olson talked about this morning, our center started off with a NIH Fogarty International Center grant. It was called a Framework for Global Health grant about 15 years ago now. And the grant was designed to bring schools together on campus around global health. And that center flourished over the years, particularly under Miriam Laufer and then Dr. Jody Olson's leadership, to become what is now the Center for Global Education Initiatives. And this Interprofessional Global Grant Program is something we've been doing for, I think, 10 years now. In fact, it's our anniversary year. And what we do is support faculty, four of whom are on the panel, I think, who have gotten grants from our center in the past. These are small grants that we give to faculty who agree to bring students from more than one school along on their international projects. And so typically faculty are always willing to bring students from their own school along. And this idea is we provide a small incentive to promote interprofessional education in the area of global health. And we've had many projects over the years. We made our application and selection criteria for faculty quite easy and open to access, I hope, because we didn't know what type of ideas faculty would bring to us, what type of projects they would like to involve students in. And over the years, we've gotten research proposals involving students in research, involving students in capacity building and developing workshops, and it's been a pleasure over the years to see these projects and how they've evolved, and you'll hear more about that on the panel. I just want to point out that several of the projects on just this simple snap from our webpage involve several of the countries that are represented here. David Riedel with intravenous drug use practices in Rwanda had a project. Cassidy Klassen from Zambia worked on an antimicrobial resistance project. A project in Nigeria and Costa Rica. So we're very proud of the diversity of projects we've supported for students, and you'll hear more about that. Another program that we recently started at our center is called the Glow Baltimore Fellows Program. Again, it's a small stipend to faculty who propose either creating a new course with global content or taking a course they've taught and adding new modules or revamping it with global content. So we just, a month ago, selected 8 fellows from across 6 of our 7 schools who will be creating new classes or revamping old classes with global content. And that is designed primarily to make sure that we are teaching global education in different ways and not all of them involving getting on an airplane. These are courses that will be taught here in Baltimore, and some will involve faculty. In fact, Caroline Burry here is creating a COIL course that she'll tell you about, which is Collaborative Online International Learning. It's a way, and this is a picture of that, it's a way of teaching a course simultaneously while the course is being taught overseas with a shared syllabus, joint student projects. And Caroline has been involved with has an environmental COIL course with Rajagiri University in India, and as a Global Baltimore Fellow will create one with Botswana. And we also have global health certificates on campus. One is through our Office of Global Health that Dr. Yolanda Ogbolu runs. Hers is an interprofessional certificate that's both in person and partially online. She'll tell you more about that. And we have a global health certificate through our UMB graduate school, and you'll recognize Jody Olson here, who helped start the online global health certificate. We are awaiting a fifth speaker who missed his plane last night. He's in a taxi right now, so he may fly in. He is from Costa Rica. He runs the Center for Global Health in Costa Rica, and he is helping us at the graduate school start a new program. It's an in-person global health certificate, a one-semester certificate in global health innovation in Costa Rica, and that will start in spring of 2020. So he will tell you more about it when he comes. So without further ado, we will start with Dr. Joanna Gaytan, who is an assistant professor at the Division of Occupational and Environmental Health at the School of Medicine, to talk about her project in the Gambia. And so I don't have to keep coming up, I'll just introduce the other panelists. This is Professor Mike Vesely from the School of Law. He will talk about his project in Costa Rica surrounding the Zika virus, for which he took a multidisciplinary group of students. Caroline Burry from the School of Social Work, talking about her innovative COIL courses. And again, Dr. Ogbolu from the School of Nursing, talking about the Office of Global Health and her work and research with students across campus. Thank you.
Okay, good afternoon. So I'm Joanna Gaytan, and I've been lucky enough to receive some of the funding to take students with me to the Gambia. And as you can see up on this slide, there's actually two names listed. There's my name, and then there's also Dr. Melissa McDermott, and she is my division director, who unfortunately cannot be here today because she is off doing global health work in Vietnam as well as Beijing right now. So she's sends her regards and wishes that she could be here. But I do have to mention her because a lot of this work in the Gambia started with her. And so for those of you who don't know, going back here, Gambia is a very, very small country in Western Africa, which is great because it's a small country. You can get things done pretty easily. And so it's a country that is completely surrounded by Senegal, if you're familiar with that area at all. And it borders the Atlantic Ocean. And right through the middle of the Gambia, there's a river that separates the country, which does make it a little bit challenging at times. And so just a brief word about our division. We are the Division of Occupational and Environmental Medicine. And so we are a PAHO, a Pan American Health Organization / WHO collaborating center for occupational health. And as part of our terms of reference for what we are going to do for the WHO is we say that we are going to support them in their global plan of action on workers' health with an emphasis on the healthcare sector. And so anyone in occupational medicine knows that the healthcare industry really is what we call a high hazard industry, as healthcare contains all types of almost every hazard class that you can think of. There are physical hazards, there are biological hazards, chemical hazards, radiological hazards, psychosocial hazards, and the list goes on. So we know that exposure to these various hazards can really have an impact on the health sector as a whole. And so it can result in individuals leaving the workforce earlier than anticipated. And we saw this early on in some of the areas where we had high prevalence of HIV, and particularly in some of the African countries who had lost a lot of nurses due to exposure to HIV, and so their health sector really had really quite a negative impact. And so losing, I like the quote that we have up here, losing its workforce can bring a fragile health system close to collapse. And so WHO over the years has really been working on strengthening the healthcare system. And so we know that over recent years, there's really been a lot of significant progress in reducing mortality and morbidity due to things like HIV, TB, and malaria. But really, in order to sustain this progress that we've made, we have to have a strong healthcare system. And so the only way that we can do that is to make sure that we have all of the building blocks in place that are needed to support the infrastructure of a viable health system. And one of those pillars is the health worker. And so we have to do everything possible to be able to retain healthcare workers who can carry out the mission of global health by providing them a work environment that is safe and supportive so that they can carry on with their mission. And so our work really began in 2014. At that time, Dr. McDermott had received one of the grants to take students with her over to the Gambia. She was introduced to a gentleman there by the name of Dr. Bill Roberts, and he is not pictured up here, but Dr. Bill Roberts is actually a professor at St. Mary's College over on the Eastern Shore. And just a little bit of background, he started out working in the Gambia as a Peace Corps volunteer back in the 70s, I believe, and later went on to establish what he called a peace program, which is a promoting educational and cultural exchange program within the Gambia. And he had that active for over 20 years. And so remember I said that the Gambia is a very small country? Well, Dr. Bill Roberts knows just about everybody in the country, I'm convinced. And so he was really our entree into the Gambia and introduced us into many very talented, very energetic leaders within the Gambian Ministry of Health, as well as the University of the Gambia. And so in 2014, Dr. McDermott, along with students, went over there to really build relationships and to engage partners and see if they were interested in working with us on part of the initiative to strengthen the healthcare system, within their own country. And so they were very generous and opened their doors and let us in. And so Dr. McDermott, the first thing that she did when she was over there, in addition to building these relationships, is she pilot tested an occupational health and safety toolkit. And so this was really 3 different tools that were developed to help organizations figure out where they were on the spectrum of providing occupational health services. And so the first tool that was developed was an occupational health and safety dashboard, which identified some of the key elements of an occupational health and safety program that should be in place. And so she had asked several people to complete this form just to give us an idea as to where the country was at that point in time. And so there was also an employee workplace safety climate survey. And so this really gets at some of the perceptions, attitudes, and belief among management and the employers so that they can identify what may be potential barriers or what may be some potential assets that can help in addressing some of the occupational health and safety issues. And then there's the occupational health service asset map. And so this was a tool that was developed to help organizations identify both local and regional resources that they may have available on hand that can help provide assistance when really starting to tackle the issue of providing occupational health and safety services to healthcare workers. And so, building on what was done in 2014, I was lucky enough to go along with Dr. McDermott in 2016, where we actually did a Train the Trainer workshop. And so, in collaboration with our Gambian partners, we developed a 3-day workshop, which was really focused on minimizing the risk of exposure to bloodborne and airborne pathogens. We had 4 students go along with us on this. We had 2 from the School of Medicine, 1 from the School of Social Work, and even a dental student. And I can say that every single one of the students, even though they were sort of skeptical at the beginning about what their role would be, they all figured out exactly what their role was as time went on, and recognized that occupational health in itself really is a multidisciplinary field, and so everyone does have a role. And so we did this 3-day workshop, and it was really modeled after a curriculum that was developed by the ILO and WHO called HealthWise. And what HealthWise does is it really focuses on and encourages managers and staff to work together to improve workplace practices. And so you can see this is the class that we put together with the assistance from the ministry, where we had individuals from many backgrounds sit in on this 3-day course. So we had nurses, we had physicians, we had laboratorians, we had infection control, we had people that had some training in occupational health and safety. And so the idea here was to train these individuals to go out and train others back at their local facilities on what can be done to improve the occupational health and safety of health workers. And so one of the most impactful exercises that we did during this 3-day training event was we did a facility walkthrough exercise. And so we actually toured one of the main teaching hospitals in the Gambia, and we had checklists that were developed so that the people that sat through the 3 days of training, we didn't just talk about what some of the issues are and what some of the hazards were, but we actually had them go out and do a walkthrough of the local facility and identify the hazards themselves. And so, it tended to be the easy part. After 3 days of talking about stuff, they were really quick to identify the hazards. But then we came back together, and what we did was we focused on, okay, you've identified the hazards, now what can we do about it? And, oftentimes we hear, well, we can't really do anything about it because we don't have the resources. And in occupational health, we always say that's not a good answer. Because there are many interventions that can be done that can be done at no cost, and there are some that can be done at low costs. And obviously, we would like to have endless resources, but it's not possible. So we do focus on things that are easy to tackle, and that way it gives them some empowerment and some excitement to move forward and start tackling some of the more challenging things that do require resources. And in 2018, we went back once again to the Gambia, and so this time we had 4 new students. We had 1 nurse, 1 social worker, and 2 students from the School of Pharmacy. And so we went back, and one of the first things that we did was we conducted walkthroughs of 3 healthcare facilities again. And one of those healthcare facilities was the same facility that we had visited in 2016. And so it was really quite encouraging to see that there were several changes that had taken place while we were gone. And so this was, very exciting for us because we did have quite a few very energetic, very talented, very ambitious participants in our 2016 training that actually took action once they got back to their individual facilities. And so the rest of the time what we spent doing was we reconvened the entire group that we had put together in 2016. I think just about everybody was able to come back, which was amazing. And we worked together to develop an occupational health and safety policy specific for healthcare workers. And so the policy the way it was developed, they wanted to focus on 3 main priority areas. And so one of them was reducing exposure to bloodborne pathogens. One was control of airborne hazards. And the other thing that was not on our radar screen initially, but definitely was on theirs, was the proper management of medical waste. And so over course of several days, we worked together in small groups, and they drafted sections of a policy to put forward within their own internal government system. And so it was very encouraging, because not only did we draft a policy that was starting to gain some momentum, but they had also developed some tools that could be used to help some of the facilities implement the policy once it was pushed forward. And so our work in the Gambia is not done. We are going to continue our collaboration with the partners to move this policy forward. And so right now, of course, they're in a little bit of flux because there has been a change in leadership within the Ministry of Health. And so it's sort of, taken a few steps back, but that's okay, because we're going to continue to push forward. The next step is validation of the policy, and then hopefully to implement the policy at the local level. And so the other thing that we are also currently underway with is working with the School of Medicine there to evaluate the prevalence of hepatitis B surface antibodies and to conduct TB skin test surveillance within the health workforce as well. And so, thank you.
Good afternoon. Thank you all for sharing some time with me today, because this is really fun for me. I get to talk about a really rewarding trip I experienced with some really remarkable students here at UMB. The only I don't want to hide the ball, full and fair disclosure as a lawyer. I had hoped to recruit students from the law school to accompany us on our trip and didn't get any takers. But when we went to Costa Rica, we were able to recruit 2 medical students, 1 student from the School of Pharmacy, 1 student from the School of Nursing who's doing the undergraduate baccalaureate, 1 who's from nursing who's doing the PhD, and a student from the School of Medicine pursuing her MPH. So we had a very diverse group, and we were asking them to do something that was fairly different from their general studies. When we went to Costa Rica, the kind of impetus for this project was some of the translational research we had been doing at the Center for Health and Homeland Security here at UMB, which originated primarily here in Maryland in Montgomery and Prince George's counties. Working with the Prince George's County Health Department, the Prince George's County Office of Emergency Management, and the Montgomery County Office of Emergency Management and Homeland Security. A few years ago, the state was asked to conduct something called a THIRA, a Threat Hazard Investment Risk Assessment. And basically, local jurisdictions throughout Maryland were asked to use targeted metrics to figure out what are the biggest homeland security, natural disaster threats, public health threats facing the state. We on all of these kinds of threat assessments, we always tend to skew high towards terrorism. It just the kind of the psychological response that people have to it always just shoves it to the top of the risk assessments. But trying to look at this in a more quantitative fashion, it became apparent in Maryland that even with the proximity of DC, even with some of the technology corridor and likely targets in the state, some of our health threats were far outreaching our terror threats. And Montgomery and Prince George's County wanted to get ahead of emerging infectious diseases like Zika, especially with the difficulties the health department experienced in distribution of medical resources during H1N1 because of the inability to employ basic emergency management concepts like ICS, the Incident Command System, like using some of the common terminology dictated by the National Incident Management System. It became apparent that there's not the kind of threat that exists, this adaptive threat that's coming from vector-borne diseases, is only exacerbated by the inability of some of our, or the lack of preparedness in some of our key response organizations, the kind of frontline responders. So, in addition to this emerging threat, I should have said I'm working for the Center for Health and Homeland Security at the university as well. We work on a bunch of different types of Homeland Security issues, ranging from local health all the way up to counterterrorism for the State Department. So one of my colleagues, she couldn't be here today, Professor Trudy Henson, was my co-lead on this project. She was the one who first voiced this concern in Maryland that, one, Zika is coming. Like, with climate change, mosquitoes are moving north. They are bringing new tropical diseases further and further north every year. And we're starting to, we have to get ahead of that. In Maryland, there was an insufficient amount of planning and preparedness applied to that at the local level. And something when she said that to me, it clicked in my mind, because I had been working for the Anti-Terrorism Assistance Program in the State Department and had done some work in Ecuador and Colombia. And both of those governments, I just remember them in passing saying, if you want to know who handled Zika well in South and Central America, you have to look at Costa Rica. They were able to get ahead of it. They were able to put in controls that limited the spread, especially as it moved north through Panama. Costa Rica took an extremely aggressive approach. And when we took our team to Costa Rica, we were kind of it was a new experience for us not working with law students. But one, we were trying to get future clinicians to think about the larger policy issues that go into things like public health and disease control. Think about what some of the deficiencies are in our own system. What lessons can we export from Costa Rica back directly into Maryland? And perhaps what are some of the things that we could share with our counterparts in Costa Rica? The other unfortunate thing is Virginia referenced that Dr. Faerron is not here yet. He was my primary point of contact in Costa Rica and opened up numerous doors for us to interface with high-level officials and private sector professionals that even using Ambassador Makaya's relationship with the university, we just wouldn't have been able to get into without him. And I would have liked to thank him in front of you all, but he's not here yet. He's in a cab. So the one thing we were very, very cognizant of going in, having been a practitioner in emergency management for a long time, there's no simple solution to say, implement this kind of vector control and you'll knock out disease. Do this kind of education and you'll limit the spread of this infection. You have to take a multifaceted approach whenever you're dealing with any of these Homeland Security or emergency management issues. So if we got something right with our students, it was making sure we engaged with sufficient partners in the country. These initially ranged from their La Nacional, which is their major paper of record, and their Ministry of Education and their Ministry of Public Affairs. We needed to see how they were creating messaging and getting it to their citizenry. This was one of the major lessons that we brought back to the United States. Now, admittedly, there has been some reticence on the part of local government to use the aggressive messaging like they use in Costa Rica. However, the notion of educating children and taking home lessons, frequently in many communities, children educate their parents. The things they learn in school, whether it's fire safety, which we've been doing for a long time, or eliminating, vector-borne disease, it starts with children in schools and then bringing that information home to their parents. And Costa Rica does that extremely effectively. What they do is they create incentive programs where children are sent home to destroy sources of water that accumulate in their own yards and neighborhoods, which is obviously very difficult and challenging when you're in a climate like theirs. And we have been, in Montgomery and Prince George's County and working with HHS a little bit at the federal level, we've been able to encourage them to create programs that educate children. Now, Costa Rica has taken that a step farther and created incentive and prize programs for children who actually destroy vectors for disease, and we haven't been able to take that step in the United States. But it's something that we're pushing for, at least to try in Montgomery County in the years that come, with Dr. Stoddard, who's the head of their OEMHS, Office of Emergency Management, Homeland Security. Another major point, if there was a hard lesson that we learned very quickly going into Costa Rica, was taking our scientifically minded health students through a crash course on law. We missed the mark on how we should have focused those studies. we tried to introduce them to some of the most basic federal laws that govern public health emergencies and federal response and disaster declarations in the United States. It was far too specific for those students because what we encountered in country dealt quite more with fundamental questions of due process, eminent domain, property rights, individual liberties. Those are the kind of issues we should have briefed our students on before going. So the most eye-opening moment for me was after we met with the primary group of officials in San Jose, which is the capital, kind of central west, high elevation Costa Rica, where Zika isn't such a big threat. We took our students to the Caribbean side of the country, Limon, where much higher temperatures, much lower elevation, much more outbreak of the disease, and the primary cases they are monitoring all originated from that region. We actually went into the field with our students and saw how health inspectors interface with citizens on their properties. One, it's kind of like a police no-knock warrant. For those of that might be a point of reference, you knock and just enter. And then anything that's deemed dangerous is broken on site. That was something that we had to take back our students and be like, this might be very effective in the moment for eliminating sources of water where mosquitoes can breed. You can't do this in the United States. You would immediately face, pushback, lawsuits, people being voted out of office. Now, some of that has to do with, the structural challenge, or the kind of way civil liberties are recognized here and how vigorously they are prosecuted. But on the other hand, some of it has to do with how Costa Rica how the populace of Costa Rica sees its risk profile. In the United States, even if you were being aggressive in entering property like this way, if you were able to bring it under the guise of some kind of counterterrorism, the penumbra of counterterrorism, you might have more leeway and less citizen pushback. In Costa Rica, even though, there is a recognition of the danger of Zika, the kind of population's immediate recognition of the danger of dengue puts this, I don't want to say fear, but this immediate concern and recognition of why these programs are so necessary and why they have to be invasive. We don't have that here, especially in Maryland. So if we had briefed our students more fully on what does it mean to have like a privacy interest or a liberty interest, or what does the government need to enter a property, as opposed to trying to take them through our own version of the Emergency Management Assistance Compact or the Stafford Act, and trying to draw out these very, very nuanced differences between what does a state of emergency in Maryland mean versus what does a state of emergency at the federal government mean versus what does the state of emergency in Costa Rica mean. That was probably a well-intentioned but misguided approach on our part. And in future iterations of a project like this, we would take a far more generalized approach to law and policy than trying to call out these specific statutes and policies that drive American response versus what drives response in Costa Rica and Central America. Now speaking of calibrating properly legally, if we did get something right, it was downplaying the issues of federalism, because while there are some independent governances in Costa Rica, they certainly don't have the division of local, state, federal that we have, where you have all of these different impediments at various levels of government. If a proclamation originates from the federal government, it just flows over everything. They don't need to worry about, well, Maryland opposes that, or Washington State is not going to be on board with this. There's a much more kind of efficiency in when these declarations can occur and how they get implemented. These are some of the statutes we specifically did not address with them in terms of calibrating what kind of legal background we wanted our students to have as they entered and interfaced with the various professionals they were going to encounter. So our initial kind of approach was, let's talk to media and community activists first to see how they were responding to Zika outbreaks, how they were trying to curtail the spread of the disease. And from there, we'll move into some of the more clinically oriented professionals and institutions. So if you can envision it, we thought of the way we envisioned it was think about it from how does the public find out about an outbreak? And then how do we track that back to the government finding out? So we went from talking to the editors of the paper of record, then moving to the Centralized Laboratory in Costa Rica, which is called InCienza. It's where they do all of their testing for cases of Zika. And then, once our students had been able to see that progression of this is how the media gets it, this is how the public receives it, this is how the lab confirms it, this is how the Central Security deals with it, let's go into the field. So good to see you. So good to see you, buddy.
Sorry.
Let's take our students into the field and see how, what decisions that are made in San Jose in the centralized government, how they get implemented in the far provinces throughout Costa Rica. Another thing that Carlos and his team were instrumental to in structuring this project was in the world of Homeland Security, we use something called HSEEP, the Homeland Security Exercise and Evaluation Program. And it's a way of building up your exercises and simulations to test various protocols throughout. And you start very, very simple, and you move up to, a full-scale exercise where you put people in the field and simulate victims, and you have everything but a real incident. What we wanted to do was make sure that throughout this process, as we added more information on the team, we could use various exercises to see what our students were acquiring on this project. So we began with a very basic simulation where one of Dr. Faerron's former colleagues, Gabby and I, gave our students a very, very kind of like, if you think back to being a kid, a choose-your-own-adventure book that went from start to finish very simply. You just make this choice. And by the end of the week, we were giving our students massive hypotheticals where they had to come up with actual outcomes, policies, and protocols. And then what we could do is look at the historical case record and see the choices they made, how would that have translated and matched up with those historical outcomes. Yeah, 1 minute, okay. So the last thing on our trip was Costa Rica has, they use a model where you have the regional clinics, or you have clinics moving up to regional hospitals, and then you have your national level hospitals. And the final, most moving, powerful part of the trip was taking all of our students to the National Children's Hospital, where we worked with the physicians who are actually managing the cases of children who have Zika manifesting completely, and got to hear about what does it take, not just from a treatment perspective, but from a holistic soul perspective to handle a child that's got this condition, that's got this lifespan and these limitations that are the reality you are not going to change. And how do you deal with that? And I think both for myself and for our students, that was the most moving part of this trip. And to put it at the end so it resonated when we walked out of there, and what it takes to be a professional under these circumstances was the most moving part of the trip and the most valuable part of the experience for me.
Yeah. Well, hi. Happy to be here. And we'll jump right in. So I'm at the School of Social Work, and I'm going to talk about COIL, and I'm going to move my own slides. Here we go. Do not make me use my social worker voice. Partly I just like the slide, but mostly I showed it because although we did hear from Jody about social work and interdisciplinary work, I think I want to use this slide to say this is a way we are taking the social work voice elsewhere. Appreciate it. So is anybody using COIL already? Okay. Well, it is exactly what it says, and I'll explain about two sort of big aspects. One is that it is a way, using technology,
to bring students from different schools, and it's specifically designed, the International piece, from different countries together in an electronic classroom with as much synchronicity as possible. So developed together from the start and taught together. So there's faculty and guest speakers from both schools, as well as students working together in the classroom and hearing everything, but also they could work in small groups outside of the regular classroom experience. And then the second big piece of COIL, and just terribly exciting, is this is something free that you can use because they have a whole model, a whole system at COIL for developing such courses. So this started at SUNY, and all the campuses in SUNY campuses in New York are very involved. Here's the website, easy to remember, I think. And I think it's probably on your flash drives as well. So the COIL Resource Guide, they don't call it the complete guide to everything, but I do, because it is a document that includes under a Creative Commons license, which means when you download the COIL Resource Guide, you can change it, keep it, trade it, share it with your friends, like baseball cards, and you just at no cost, and you just give credit to that it's under the Creative Commons license. So that's the free part that's really terrific. And in the resource guide and on the website, they have courses, course syllabi, videos, everything from how to develop to how to evaluate your course. And there are already 40 countries, more than 40 countries, and these are listed, updated all the time on the COIL website. So if you're thinking of teaching a class with another country, you can look where there already are those partnerships. But if not, you can start one, which is what we're going to do. So we are at the School of Social Work developing a course we're very excited about, interdisciplinary HIV services, and learning from the differentiated care models in Botswana and Baltimore, which I want you to hear the global and the local there. We're expecting to learn absolutely as much from Botswana as we are going to be teaching about what is going on in Baltimore, work that many of you are, in which you are involved. And I do want to thank, as Virginia mentioned, the Center for the Global Center here that is supporting the development of this class. So I'm at the School of Social Work. Sally Bjornholm here in the audience, graduate of our school and now in Botswana through IHV, and the University of Botswana social work faculty are working together to develop this course, which we'll teach next year. So we're going to use WebEx, possibly Zoom, depending on what is working better at the moment in time, but I think we're going WebEx on the campus. So we'll have the real-time synchronous classes, and we can also, this is a very US reference, but we can also do a Hollywood Squares-like thing with multiple virtual groups meetings so that you can see everybody at once. So like a speakerphone, but with pictures. Also, of course, be able to look at PowerPoints, documents, desktop, etc., and the small group discussions. And then the students can also work together at other times. So much like a class here, because it is a class here, you have those different modes of teaching and learning. So we're sharing in the development. We will have students at UMB, not only from social work, it's classes housed in social work, but it will be open to students from the other schools. So you'll be seeing some outreach materials about that in the fall. With that experiential collaborative learning, we'll have some sessions in this coming fall. We are going to also have an in-country piece, so a 2-week trip to Gaborone and environs in January 2020, where our students will get to be in the classrooms with the students from the University of Botswana. And then we'll finish again with the online piece back in the spring. One of the other benefits, I mentioned this is free, it really is cost neutral to schools to do this, because we're not doing exchanges of tuition back and forth. Our students pay our tuition, are graded by us, and the students in the other school pay tuition to their schools. So it's a little less complex and also sort of more affordable, particularly usually to our partnering countries. And challenges so far, because we've just done this with a class with India, and internet access and power access. Now, I don't just mean in the other country. See, Baltimore, city of. Those of you who are visiting may not know that our city government in Baltimore has been hit by a ransomware attack. So the city computer system is not working. So it could be on either or both ends that you would have some of those technical challenges. With Botswana, we've got a 6-hour time difference. With India, we have a 9.5-hour time difference. And so your windows to overlap for the synchronous parts is challenging, but it's doable. And again, the guide, the COIL resource guide, is just a cookbook in terms of do this, do this, do this, do this, things to consider. We have different term lengths, so that's kind of a challenge. Of course, we actually share that challenge on this campus. Our schools on the campus have different calendars as well. So we're hoping with the, from the school social work, with the subclasses in the fall and the trip, and then in January and classes in the spring, as has worked well with other classes that we've done similarly, that it will enable our schools, other schools on the campus, to have students involved in or take this class. And then just the constant, this is possibly by Shaw, but divided by common language. You know, we're speaking English in this class, but we're speaking American English, and they'll be speaking Botswanan English. I'll be speaking South Carolina English. I mean, these are all, different aspects that can be challenges, figuring things out. My not surprisingly, my spell check, when I put in P-R-O-G-R-A-M-M-E, because that's what we're trying to use, it corrects it every single time, even though it is correct in a British-based English system. So you figure those things out. We say clients, they might be saying patients. In our work in the UK, they say service users, so we have to sort out those things. But that's also, I think, one of the benefits to the students is learning how to communicate. Even if it's all in the same language, there still are cultural and social differences. And yeah, just hard to find funny cartoons about online learning, but I would actually like an airbag on my computer when I have computer issues. So super zoomy walk through COIL. Maybe for questions, we might have a little time at the end, but you are very welcome to email me and I can share our materials. To get the resource guide, you just have to email the COIL Center at SUNY, and they'll send you everything you need to do. But for whatever reason, they have it set up so that you actually have to email and ask for it, and then you get it, and you go from there. All right, so I hope you'll think about doing these. Thanks.
I'll put the other one in. Hold on.
Good afternoon, everyone. While my slides come up, I'm going to excuse myself for being late. I lived up to the Latino stereotype, so I hope you don't mind. It wasn't my fault. All right, I'll do this in 10 minutes. I hope my tie is not crooked. Thank you, Virginia. So I got 10 minutes to speak to you about the new post-baccalaureate certificate in global health systems and innovations that we're starting in Costa Rica in partnership with the University of Maryland, Baltimore. I put a picture up of a sloth. Everyone likes sloths, so just hoping to grab your attention here. So when we use global health as a term, it's very umbrella term, and I think everyone here agrees that we haven't yet agreed what we're saying by global health. When we use this term, global health, in Costa Rica and the team that I work in, we're usually referring to an area of study that is hopefully a science that will eventually let us lead the way to better health. And the way I see it, it's the interaction of globalized processes and their interaction with local processes. And everything that happens there in between is global health. So what we want from this certificate is for students to be able to learn much better. What are the global processes that are driving health inequities? What are the global processes that are driving innovation? And how can we apply those at a local level, understanding the different contexts that the students are going to be working on in the near future? This definition is a work in progress. Please don't cite me on it. But when we look at kind of where we place global health in this very nice diagram, for us, global health is about doing, global health is about social justice, but it's also about understanding the complexity of the societies that we live in. Not just the societies, but also our environmental context and the global processes that go into it. Complexity science brings all that together, and we need to start including these more complex understandings of global health, always with the driving force being social justice. Now, this program is a blended learning program in the sense that the students will be able to have an online component, and then they're going to have an experiential component in Costa Rica, in which the students will be exposed to both Costa Rican and US-based faculty. in different topics. And we'll try to focus on 2 different scenarios, and I'll speak to that in a second, but one will be an urban scenario and the other one will be a rural scenario, in which we'll be piggybacking on Costa Rica's experience on human rights, healthcare access, equity, universal healthcare coverage, and all the challenges that come in being a middle-income country at this moment. So here's a list of the courses that we're trying to end up writing. We're still a little bit in the work in progress, but it's going quite well. As you can see, it's a mixture of interculturality studies, peace studies, health systems, social justice, social innovation, trying to bring all that together in order to provide an opportunity for students to understand how complex global health can be. Now, I won't go over this. I'm going to skip it quite quickly. But as I was saying, the whole focus is about trying to bring the concept of innovation into global health. And what I mean about that is trying to give the student or the participant the necessary tools in order for them to be able to take those tools and apply them in a given context in which they're going to work. They're going to learn a lot about Costa Rica. Yes, they're going to learn a lot around Costa Rican context, challenges, things that we've done well. But the whole idea is through those case studies that we're going to develop in global health and social innovation, the idea is to give the students those necessary tools in order for them to apply it anywhere in the world. Okay, that's kind of the basic concept. We're not creating experts of Costa Rica. So it's important for you to understand that. Now, why Costa Rica? Is anyone, if anyone has ever heard of Costa Rica, they've probably heard of its nature and its sloths and its nice little frogs. But we're also known for other things, such as around 70 years ago, our founding fathers of the Second Republic decided to make this nation have values that speak to solidarity and universality and other words that are sometimes forbidden in this country. But through that investment in education, through that investment in environmental protection, through that investment in social guarantees, we've managed to keep the country up to the standards of high-income countries with a middle-income country GDP. So when we look at a country, and as I was saying, our investment is very much oriented to education and healthcare, and all the different good things that stem from that. You can see how the country functions, but you can also start seeing it in what our challenges are. Of course, peace is one of the main pillars of Costa Rica, as we abolished our army early on in the 1940s. So that has been one of our long-standing traditions, our love for democracy and our love for peace. And I think you speak to any Costa Rican in the world, we're a rare species because we're only 5 million. You'll hear them speak to this peace-loving concept that we carry all inside of us. And not only have we done well, but we've done it very efficiently. In this graph, you can see our life expectancy compared to GDP per capita. So if you see there, Costa Rica is kind of an outlier in the sense that we are not a high-income country when we compare to countries like USA. But we're definitely more efficient in providing better quality of life. And USA, you might know it or not, has a lower life expectancy than that of Costa Rica. When we look at competitiveness, well, Costa Rica isn't doing all that great. And that's what's a little bit about what this certificate's about, because we're not all that perfect. We also have a lot of challenges, and innovation is around trying to find solutions to these challenges. So just to say, we're not all that perfect. However, when we compare ourselves with different countries of the region, and things like political stability and democracy index and safety, definitely Costa Rica ranks high. I've mentioned this, and one of the reasons that we are doing well, as I was mentioning earlier, as you can see from this graph, is that we managed to break that paradigm that you need to extract natural resources in order to grow in their GDP. So Costa Rica is a perfect example on that this paradigm is not absolutely true. You can do both at the same time. And that will be part of the environment where the students will be immersed. How does this look? How does this connection between saving the environment or preserving the environment and not having an extractive economy and growing in our economy looks. Part of it has also been our incredible natural wealth that we carry in Costa Rica. You might have seen a lot of videos also circling the social networks around how we produce a lot of renewable energies and how that has been diversified little by little. This does not come without its challenges. Hydroelectric power is not all that good, as we're finding out, and the students are also exposed to this level of complexity in which we have a solution that has unintended consequences. Being unintended consequences is one of the main things that we want students to think of when they're thinking of the process of innovation. As you also might have heard in the news recently, we have launched our national decarbonization plan for the year 2050. This is one of the first countries to actually launch a Green New Deal, as you call it here in the US. This Green New Deal has not come without its winners and losers, but we're trying to understand what's the best way to implement this and roll this out in the next 30-something years. We're at this phase where we need to take a turning point in our economy and start thinking of these green new jobs that we need to create. Part of the challenges that we're facing is that, well, although we have a population growth rate that's quite similar to the US, things like our car rate expansion has blown up. That is, people are now starting to leave their normal livelihoods in the rural areas and come into the cities for the last 30, 40 years. And with that has come, of course, advancement in their education and in their health and well-being, but their purchasing power has also allowed them to access things like vehicles, which now has become a central part of any Costa Rican's life. And with that has come the problem of traffic jams and quality of life questions that we have to deal with. Costa Rica does not live up to its standards when it comes down to waste management. Anyone who's been to Costa Rica will know this. So these are other of the challenges that we're exposed. We have very poor resource waste management policies, and it's something that we need to start changing. Poverty has been stagnated for the last 20 years or so. So although we made great progress during the 60s, 70s, 80s, 90s, we've been stagnated for the last 2 decades, which means that there's still a lot of work to do there. And that poverty is impacting ever more women and people from the rural areas, which is why we combine these two scenarios so the students can understand what are the elements of Costa Rican society. And believe it or not, our inequities are growing, which is kind of weird because no one expects this. Costa Rica is one of the top 20 countries in the world with highest Gini coefficient, which means that we've not done a good job at redistributing that wealth that has been created for the last 60 years. The other thing is we are well on in our demographic transition. This is Costa Rica's population pyramid. As you can see, it's quite advanced. But when you take a look at special populations, such as indigenous populations, its population pyramid to your left here says a lot on how they access health services. As you can see, a strong young population compared to a strong productive population in non-indigenous society. The other thing is that although we've managed to almost reach theoretical universal healthcare coverage, there's a dimension that is rarely covered there, which is the dimension of quality. Yes, we've managed to reduce cost sharing. Yes, we've managed to produce healthcare for almost everyone in Costa Rica. And yes, we've managed to do almost everything for everyone. But the quality component is still not there yet, which is one of the questions that innovation has to look at. 1 minute? 1 minute. I'll skip to this one. Our epidemiological transition is also well advanced. This means that we've gone from a country that went on from a burden of disease that is basically transmittable diseases to a country where we're seeing a lot of chronic diseases, such as diabetes, obesity, and hypertension. And moving on to where the program will take place, as I was saying, it's going to be mainly in 2 locations. One would be in the south, in a place called Las Cruces Biological Station, run by the Organization for Tropical Studies, and we'll also be using an urban context, which is San Jose, which is the nation's capital. Some of the assets that the students will be able to look at: biodiversity, hardworking people, culture, and a multicultural scenario that the South provides. but also some of the challenges such as migration, re-emerging neglected tropical diseases, health services that are not adequate to the population, and an ever-growing push of the agricultural frontier, which is leading to deforestation in Costa Rica. Okay? The partners from the program will include everything from private sector to the public sector, as well as civil society sector, NGOs, among others. So CISG, the organization I represent, and the organization that we're partnering with, has a strong network at its base, will allow the students to immerse themselves in real-world scenarios, which will allow them to see the complexities of challenges and innovations as they are as they're emerging in real-life standards. So this is CISG in a nutshell. I won't go over all the slides what CISG is. CISG stands for the Centro Interamericano para la Salud Global, InterAmerican Center for Global Health in English. And I'll just skip through this because I'm out of time.
Sorry.
If someone wants to read a little bit more on CISG, I just want to acknowledge here the UMB team, who's been great, and they've been so supportive. I could not ask for a better partner anywhere in the world. I think they're amazing on their quality of partnership. So thank you all. I want to acknowledge that. You've done a wonderful job.
And Yolanda, we are a little over, but we have wonderful news to hear from you.
So good afternoon. It's been a great day. Yeah, just wonderful to be here talking about global health all day and to have spent the day yesterday with many of the country visitors here with us to show them Baltimore. I'm Dr. Yolanda Ogbolu, and I'm from the Office of Global Health. I direct the Office of Global Health in the School of Nursing. I've heard a little bit about nurses occasionally in the conversation today, but we all know that nurses are essential to healthcare systems, particularly in low-resource countries, where often they make up about 60% of healthcare workers in the whole country. They're the front line often for many of the projects that we're all working on. And so for us, nursing is the backbone of healthcare. This is important that this year it was recognized by the World Health Organization that 2020 is the International Year of the Nurse and the Midwife. And just that's really in recognition of all of the great work that nurses do. Our goal for this session and this presentation was really to talk to you about our educational opportunities here at the university, but I think also to help you understand kind of the value proposition. Why might this be important to our country partners abroad? And I hope that through the work that the School of Nursing has been doing, I'll share some of our projects. You'll see some opportunities to continue to collaborate with us, and as well as see some evidence of past collaborations. The School of Nursing is a top 10 nursing school. It's 130 years old, and we've been doing international health for a long time. The Office of Global Health was established in 2009, but really grew off of previous international activities. And we're forever grateful to Dean Kirshland, who's been here with us all day, for her support for the Office of Global Health and for students that are really interested in doing global health nursing. We have a big student body, and why might that matter to you is that nursing is different all over the world. Nurses are educated at different levels. At the University of Maryland, our nurses are predominantly graduate students, doctorally prepared nurses, master's prepared nurses, though we do have undergraduate students as well. In fact, the largest number of undergraduate students here on campus are in the School of Nursing. As well, we have a large faculty body with a lot of diverse interests in research, and some of you had an opportunity to come in and do a tour of our simulation lab yesterday, as well as to see that we actually have patient actors that also serve to help learning experiences.
Virginia mentioned that we have a global health certificate program, but I also like to share that we welcome nurses from abroad through our International Visiting Scholars Program to come and be mentored by faculty at the School of Nursing in their specific research interests. So we would encourage you to have nurses from your countries consider coming and spending some time with us. One of the things that you might not think about immediately when you think about nursing, depending on what country you come from, is nursing as nurse scientists. And we have research at the School of Nursing. And so these are pictures depicted of our 3 centers for global health. Our centers for research. We have a center to advance chronic pain. And this center really focuses on translational research, bringing research from the bench to actual patient care settings in the hospitals in Maryland. We also have a center for health outcomes as well as a center for behavior across the lifespan. And so this is just to speak to the richness and the diversity in terms of research capacity that we have in the School of Nursing. When we think about global health specifically and where we've been and where we're going, we've really focused in 4 primary areas: maternal and newborn health. We also focus on global to local research and global health, as well as HIV care and treatment. And one of our biggest components has been in the area of healthcare workforce development. So for me, I think a couple of people asked me earlier, how did you get here? I am a neonatal nurse practitioner. I was in clinical practice for 25 years before coming here and was invited to Kebbi State in northern Nigeria to teach neonatal resuscitation. And for me, just understanding that babies in sub-Saharan Africa are 15 times more likely to die than babies here in the US was really striking and transformational to me. So much of our work has focused in this area of maternal newborn health. And I was happy to hear many of the presenters talk about this earlier because at the time when I reached out to the Institute of Human Virology in Nigeria with this idea that I could study neonatal mortality in Nigeria using a platform that was initially designed by PEPFAR for HIV care and treatment, it seemed strange to them. And at that time, I did add on a component of prevention to maternal to child transmission to make it acceptable to them. But it's really exciting to see that we're recognizing that much of the investment from PEPFAR and from collaborations with the university could also be used to look at things like patient safety. We had the opportunity to look at maternal health-seeking behavior in collaboration with some of the programs at IHV with the University of Nairobi in Kenya. And one of our key partners in Liberia, Mother Patern College of Health Sciences, we have worked with them very closely. As someone mentioned, lots of physicians died during Ebola, but also nurses also lost their lives during the Ebola outbreak because people still had to deliver their babies, right? So people still showed up, whether it was at someone's home or at the hospital. And so due to that loss, we were able to go to Liberia and to do a neonatal training program for their nurses. We've also been involved in the Rwanda Human Resources for Health program, and we've been able to advance neonatal care there through the training of neonatal nurses in Rwanda. One of the things that I had the opportunity to talk about yesterday to colleagues while we were doing the community tour was this idea of reverse innovation. Many of us have traveled globally, and I used to always say, whether I'm traveling in Oman or in Africa, that I always come back feeling like I learned more than I gave. And so sometimes it's something that's been on my mind for about 15 years is how do we begin to give people credit abroad for what we've learned from them and take that and really implement it. And so there's this idea of global to local research as well as reverse innovation, which you can read about, and there's a reference here, that really speaks to how do we take the best evidence from around the world and implement it to improve global population health. There are many things that you're doing in different countries that could be beneficial to the US, and there's many things that we're doing here that also could be beneficial in your country. For the first time, I'm having the opportunity to implement such a project here in Baltimore, funded by the Robert Wood Johnson Foundation, which is really taking a program that was developed in Brazil to improve social inclusion for mothers of young children 0 to 3 and implement that in Baltimore. And you might say, well, they're not too similar, those two places. But when you look at the demographics, you'll find that they're very similar when it comes to geographic and racial inequities, maternal and newborn child health outcomes, as well as many other indicators. And on this picture, you can see a picture of the favelas as well as the row homes here in Baltimore. And so this project is really focusing on how can we make people feel more included. We know that social isolation is a growing epidemic globally, and we know that it accumulates over the life course. And so this project is the first of its kind to be funded by Robert Wood Johnson. And so we were thinking out of the box for funders. We didn't mention foundations, but also foundations might be an important place to look for global health funding. And this is funded by Robert Wood Johnson Foundation, which typically focuses on health in America, who said, you know, there are lots of things that we can learn from the world to improve our health. And so this program was selected as a program, and they've been really impressed with the work, so much so that they've asked us to assist them in designing a learning network that would also bring additional reverse innovation projects to the United States. We've also had the opportunity to work in the area of HIV research and programmatic activities, working on task shifting in Nigeria with the Institute of Human Virology. We've also worked in the area of dissemination and implementation science. I think we can hear more about that today, but I worked with the WHO in helping them to develop an implementation research toolkit for low-resource countries. And I know that many of you are also using implementation science in your work, and so that might be a place where we could collaborate. Most of our work has centered around healthcare workforce development. Really, at the core of our mission for the Office of Global Health is that we build nurse capacity. And so we've worked on several projects, from improving neonatal mortality by really looking at hospital characteristics and how that impacts patient outcomes. We were fortunate, and this is with Marique Moen, who was here earlier but had to step out, but I know is known by many of you, worked to develop an infectious disease nurse specialist program in Haiti, as well as working on health hazards in terms of needle stick injuries in Haiti. We worked with 3 Nigerian institutions, University of Nigeria, as well as OAU and ABU, in the development of a primary healthcare specialist curriculum for Nigeria that has also been used in Liberia, as well as the post-Ebola health system strengthening. I think it's really important to kind of help show the overlap of how we transfer our educational programs into local settings. And so our students that are certificate students often have field experiences in country. And we use that pilot data often as a basis to develop research funding. One of our students is here with us today, Dr. Trish Milburn, and I'm really excited to have her here just for a few minutes to talk about her work in the Rwandan Human Resources for Health program. And so we were very fortunate, so I'll just invite her here to speak for about 5 minutes.
Good afternoon. Thank you for having me. Is anyone in the room familiar with the Human Resources for Health program? I figured there might be, yeah, there's several hands. So I was lucky enough to go to Rwanda under the Human Resources for Health program. And what attracted me to it was that it's a 7-year program that we partnered with the Rwandan Minister of Health. So they invited us in country for 7 years. So it was a committed project. We were a big group of people, about 100 nurses, physicians, dentists, health managers that were in country together. And what attracted me to it was that it wanted the health partnership to be a sustainable partnership, meaning I would be twinned up with someone, and whatever I imparted to them, they could take and take off when I leave, and that has certainly happened. I've been able to go back and see that that did indeed happen. There were a number of U.S. institutions involved, in which Maryland was one of them. In fact, the University of Maryland School of Nursing was the first school of nursing to sign and agree to participate, and I think the only ones that sponsored the dental students, so we were happy to have that. And it was sponsored by the Clinton Healthcare Initiative. So briefly, my role in the HRH program, one of the first things that we were pledged to do was to improve the current curriculum in place for the nursing students. I was assigned to the Ramagana School of Nursing, and there we helped some of the professors with their curriculum building and with their lecturing and teaching, and helped in their simulation lab to improve that, and then also taught a lot of their students in BLS. The second thing that we were tasked with was creating a master's in nursing with a focus on critical care, and I'm happy to report that the University of Rwanda is now using that curriculum. They have a 2-year program for that, and that's already in place. Another thing that we were able to do is create a better clinical experience for the nursing students. At their clinical sites, I was assigned to the Accident and Emergency Department at Sayashika, one of the #1 referral hospitals there. And while the students were coming through our site to do their clinical experience, we were working with them at the bedside, also implementing post-clinical experience sessions, and working with, again, with teaching over 120 nursing students in BLS. And then one of the big things that we worked with was developing training and competency programs for nurses. And so what my colleagues and I in Rwanda did was come up with a 16-week emergency nursing certificate program. In Rwanda, there is no such thing as an emergency nurse. You are not, trained specifically in that. So we came up with a 16-week education nursing certificate program, which I co-directed and co-taught with my Rwandan colleagues. And a lot of the time through that program, in the clinical aspect, we were working a lot in interprofessional collaboration, working with the doctors at the bedside, being able to discuss plans, being welcome in the rounding with the patients, and then as the doctors are learning, residents are learning, the nurses are learning as well. And doctors are learning what the nurses are doing in their role, and the nurses are learning what the doctors are doing in their role, and it was very intercollaborative. And of course, at the end of the certificate program, they all got a certificate from the matron and were able to use that to advance their careers. And now I'm thinking I'd like to introduce that with the COIL program and re-implement it. So it's pretty fortuitous. So yes, it was one of the best years of my life, and I appreciate you.
So thank you very much, and if you're interested in collaborating in those areas, please reach out to us and learn more about our work.